Hello everyone, today we'll be discussing liver cirrhosis. Liver cirrhosis is a condition that is characterized by fibrosis and nodule formation of the liver. So this usually arises as a result of chronic liver injury, which leads to alteration of the normal lobular organization. So various insults can lead to injury of the liver that include viral infections, toxins, hereditary conditions, or autoimmune processes. With each injury, the liver forms scar tissue, fibrosis initially without losing its function. However, when the injury stays for a long time, most of the liver tissue results in getting fibrosis. So due to the above, there will be loss of function and development of cirrhosis. Etiology. So you need to know that chronic liver diseases, due to whatever cause, usually progress to cirrhosis. In the developed world, the most common causes of cirrhosis are hepatitis C virus, alcoholic liver disease, and non-alcoholic steatohepatitis. However, in the developing world, the most common causes of liver cirrhosis are hepatitis B and hepatitis C virus. Then there are a few other causes of liver cirrhosis that include autoimmune hepatitis, primary biliary cholangitis, primary sclerosing cholangitis, hemochromatosis, Wilson disease, alpha-1 antitrypsin deficiency, Budd-Chiari syndrome, drug-induced liver cirrhosis, and chronic right-sided heart failure. The pathophysiology of liver cirrhosis. So we'll look at this through our diagram. Okay. So what happens is, because of the injury to the liver, so the architectural changes of the liver as well as functional or dynamic changes. So what this leads to is increased intrahepatic resistance to portal blood flow. So this will lead to portal hypertension, as you can see on the diagram. So when there is portal hypertension, this leads to increased back pressure and it will lead to collateral blood flow formation. So that's why you notice varices, bypass shunts, and hepatic encephalopathy. So when there is portal hypertension, that will also lead to splenic vasodilatation. Due to the above, there will be hypovolemia. Because of the hypovolemia, there will be activation of the renin, angiotensin, aldosterone system, and the sympathetic nervous system. So this is going to lead to the following effects, which are sodium retention, hypervolemia, ascites, HRS, and cardiomyopathy. So the histopathology, so liver cirrhosis is classified based on morphology or etiology. So the morphological classification, so this classification is not as clinically useful as the etiologic classification. So there is micronodular cirrhosis, which is uniform nodules less than 3 millimeters in diameter. So this is usually liver cirrhosis due to alcohol, hemochromatosis, hepatic venous outflow obstruction, chronic biliary obstruction, jejunal-ileal bypass, and Indian childhood cirrhosis. Then there is macronodular cirrhosis, which is irregular nodules with a variation of greater than 3 millimeters in diameter. So this is usually due to hepatitis B and hepatitis C virus, alpha-1 antitrypsin deficiency, and primary biliary cholangitis. And then there is mixed cirrhosis. This is whereby features of both micronodular and macronodular cirrhosis are present. So usually macronodular cirrhosis ends up progressing into macronodular cirrhosis over time. So what you need to remember is morphological classification. There is micronodular, macronodular, and mixed cirrhosis. So in micronodular, the nodules are usually less than 3 millimeters in diameter. Macronodular, they are more than 3 millimeters in diameter. And mixed cirrhosis, this is where you're going to see both micronodular and macronodular features. However, this is usually believed that it starts off as micronodular, then it progresses to macronodular liver cirrhosis over time. Then etiological classification, so this is based on the cause of liver cirrhosis, which is subclassified as follows. So viral due to hepatitis B, C, and D, toxins due to alcohol and drugs, autoimmune hepatitis, cholestatic, which is primary biliary cholangitis, primary sclerosing cholangitis. Then vascular, we have got Budd-Chiari syndrome, sinusoidal obstruction syndrome, cardiac cirrhosis. Then metabolic, we've got hemochromatosis, non-alcoholic steatohepatitis, Wilson disease, alpha-1 antitrypsin deficiency, and cryptogenic cirrhosis. Then on history and physical examination, what will your findings be? So patients with liver cirrhosis can be asymptomatic or symptomatic. So this is This depends whether the cirrhosis is clinically compensated or decompensated. So in compensated liver cirrhosis, patients are usually asymptomatic and the disease is detected incidentally by labs, physical exams, or imaging. One of the common findings is mild to moderate elevation in aminotransferases or gamma-glutamyl transpeptidase, which with possible enlarged liver or spleen on examination. So patients with decompensated liver cirrhosis usually present with a wide range of signs and symptoms that will arise from a combination of liver dysfunction and portal hypertension. The diagnosis of ascites, jaundice, hepatic encephalopathy, variceal bleeding, or hepatocellular carcinoma in a patient with liver cirrhosis signifies the transition from a compensated to a decompensated phase of cirrhosis. So other cirrhosis complications include spontaneous bacterial pneumonitis and hepatorenal syndrome. This occurs in patients who have ascites. So if you can look at the diagram that's on the side, you'll see there will be jaundice. They may present with hepatic encephalopathy, presenting as confusion, spider angioma, lack of body hair, muscle wasting, widened blood vessels, ascites, then palmar erythema, which is red palms. So we need to know that multiple organs are affected in liver cirrhosis. So under gastrointestinal, portal hypertension can cause ascites, hepatosplenomegaly, and prominence of periumbilical abdominal veins that result in caput medusa and esophageal varices. Hematologic anemia can occur due to folate deficiency, hemolytic anemia, and hypersplenism. Then renal, we've got hepatorenal syndrome, pulmonary, hepatopulmonary syndrome, portopulmonary hypertension, and hepatic hydrothorax. Then skin, they'll present with spider nevi, palmar erythema, jaundice. Then endocrine, hypogonadism, and gynecomastia. Hypogonadism can lead to decreased libido and impotence in males, and leading to loss of secondary sexual characteristics and feminization. Women can develop amenorrhea and irregular menstrual bleeding, as well as infertility. The nail changes, you may see finger clubbing, hypertrophic osteoarthropathy, and the deep uterine contracture. Other nail changes include azaleal nails, which are seen in Wilson disease, Terry nails, and Mohawk nails. Other features include feta hepaticus and asterixis. Then physical examination in patients with liver cirrhosis may reveal stigmata of chronic liver disease, which is spider telangiectasia, palmar erythema, deep uterine contracture, gynecomastia, testicular atrophy. Then signs of portal hypertension, which are ascites, splenomegaly, caput medusa, Crowley, Baumgarten murmur, epigastric venosum. Then signs of hepatic encephalopathy, which are confusion, asterixis, and feta hepaticus, and other features such as jaundice, bilateral parotid enlargement, and scant chest axillary hair. Then evaluation. So on lab findings, you will notice liver enzymes, aminotransferases are usually mildly to moderately elevated, with AST greater than ALT. Then ALP, 5 nucleotides, and GGT are elevated in cholestatic disorders. Then prothrombin time is elevated due to coagulation factor defects and bilirubin, while albumin is low as it is synthesized by the liver. Then normochromic anemia is seen, however macrocytic anemia can be seen in alcoholic liver cirrhosis. Then there may be leukopenia and thrombocytopenia, which are seen secondary to sequestration by the enlarged spleen, as well as alcohol suppression effect on the bone marrow. Then immunoglobulins, such as especially the gamma fraction, they are usually elevated due to impaired clearance by the liver. Then on imaging and liver biopsy, ultrasonography is usually the first line imaging that we do. So this is a cheap, non-invasive, and available modality for the evaluation of cirrhosis. It can detect nodularity and increase echogenicity of the liver, which are seen in cirrhosis. Then you can do a CT and MRI with contrast. This can detect hepatocellular carcinoma and vascular lesions. MRI also can be used to detect the level of iron and fat deposition in the liver for hemochromatosis and steatosis and biliary obstruction if an MRC is obtained. Then transient elastography, which is a fibroscan, is a non-invasive method that uses high-velocity ultrasound waves to measure liver stiffness, which correlates with fibrosis. Then liver biopsy is the gold standard for diagnosing liver cirrhosis as well as assessing the degree of inflammation, which is the grade, and fibrosis, which is stage of the disease. Then treatment and management. Damage to the liver is permanent. Nevertheless, further injury to the liver should be avoided to halt the progression of the disease. General management to prevent chronic liver disease includes avoidance of alcohol, vaccination for hepatitis B virus and hepatitis C virus, good nutrition with a balanced diet, weight reduction, and early treatment of precipitating factors like dehydration, hypotension, and infections. So this is usually achieved by routine monitoring of volume status, kidney function, viruses development and progression to hepatocellular carcinoma. And specific therapy usually targets the etiology. So if it's a viral etiology, you want to treat the virus. If it's due to toxins, you want to make sure the body gets rid of the toxins, etc. Then complications of liver cirrhosis include portal hypertension, edema in the abdomen and lower extremities, jaundice, splenomegaly, infections, hemorrhage, hepatic encephalopathy. That's all about liver cirrhosis.